Good evening, everyone. This is our 21st online teaching class under the banner of UB Chapter URI.
I would like to invite Dr. Sushma Agrawal, ma'am. Ma'am is professor in Department of Radiotherapy in Sanjay Gandhi Postgraduate Institute, Lucknow. Ma'am is graduate from Mahatma Gandhi Institute of Medical Sciences, Bardha, and postgraduate from Institute of Medical Sciences, Banaras Hindu University, Varanasi. Ma'am has won many awards and published many papers in national and international journals. Now I am handing over to ma'am. So Dr. Sushma Agrawal.
So today I shall be talking about locally advanced breast cancer. So let's see which are the patients who are locally advanced. We can define locally advanced into two varieties, that is operable and inoperable. Operable is stage 2B, which is T2 and N1. And here the intent of treatment is to downsize so that the patients become eligible for breast conservation. While the inoperable ones are the stage 3s, and as you can see here, the patients are more than N1 and even T4s are there. And here the intent of treatment is to downstage for resectability, first of all. And if BCS is possible, then well and good. Otherwise, mastectomy is also a good option. So now let's see what is the flow chart in short about LABC. So when a patient of LABC comes to us, what we do is we rule out metastatic disease, and then we do a true cut biopsy. Why? Because we want to know whether the patient has HER2 enriched or triple negative. Because in these two subtypes, we have to be very vigilant. And in HER2 enriched, we have to add anti-HER2 therapy. In triple negative, very often we see that the patients don't respond, and cisplatin-based chemotherapy should be given in such cases. Now coming to further, once we know the histological subtype, so then if the patient is operative, so these patients are submitted to a standard neoadjuvant chemotherapy, which is a combination of AC, 4 cycles AC, followed by 4 cycles of either DOSI or PACLI, which is given weekly. And if the patient is HER2 positive, you can see on the right side, you have to give trastuzumab and pertuzumab. Now, if the patient becomes operable, then you look for whether he or she has become BCS appropriate or not. Whichever is possible, that surgery is given, and then radiotherapy is given to these patients. And if the patient does not become operable, as you can see on the right side, then what to do? So there in these cases, you can give pre-operative radiotherapy to downsize the tumor, to see if the patient becomes operable. And if still the patient doesn't become operable, then this becomes a palliative case. Now, after having seen this flow chart, let's see how did the rationale for neoadjuvant chemotherapy evolved in advanced breast cancer. So basically, initially, the T2s and N1s were taken in the study, and people wanted to see whether any improvement in breast conservation was possible, and whether inoperable could become operable. So as you can see in this diagram, here the tumor is so big where BCS is difficult, and if you downsize, BCS becomes possible. The other thing which gradually evolved was the improvement of sentinel lymph node procedure rates. Since sentinel lymph node procedure is done in clinically node negative patients, so if we give chemo to node positive patients, they become negative, we can go ahead with sentinel lymph node procedures, and we will end up with a lower incidence of lymphedema. Now, what were the other advantages? It also resulted in a decrease of the local and local regional recurrence rates. It also results in decrease in breast cancer mortality, thus leading to an improvement in survival. So this was the pivotal study, the NSA BP18 and B27. And this was such an important study that it has set the stone rolling for most of the developments which has happened in this field. So what was it? So first B18 was done, and basically people wanted to be sure if we adopt this strategy, will the survival be same? So it was a very simple two-arm study where the standard of care was surgery followed by chemo, and the other arm had 4 chemo followed by surgery. And subsequently, they intensified the chemotherapy in B27. And mind you, they were all T1 to 3 and N0 to 1. They were operable. So what did they do? The first arm was standard, that is AC into 4 followed by surgery as seen in B18. The second was they added docetaxel and then followed them with surgery. And the third was upfront chemo and post-op chemo. So total of 3,000 patients were there. And the other important thing which you should keep in mind is that radiotherapy was given to breast only in lumpectomy patients, and in mastectomy patients, no radiotherapy was given. So what did they see? So they saw that in the second study that the PCR rate, that is pathological complete response rate, improved from 13 to 26% with administration of docetaxel. The other thing was that there was an enhancement in the BCS rate by 10%, 60 to 68%. And at the same time, the survival was same in all the 3 arms. So, and so therefore, if BCS is possible in larger number of patients, obviously cosmesis would be there and the outcomes were similar. Now, let's see what was the impact of we just saw the impact of neoadjuvant in tumor. Let's see what was the impact of NACT in node-negative axilla. As you can see, why is it so important to see? Why? Because if you do upfront surgery, the incidence of nodal positivity in a node-negative, clinically node-negative axilla was 50%. If you downstage with chemotherapy, it becomes 30%. So what happens is that 10 to 20% patients, more patients are eligible for sentinel lymph node procedure. So this impacts on lymphedema. So now let's see what is the impact of NACT in node positive axilla. Here they saw that the pathological response rate, complete response rate in a node positive ranged from about 35 to 60%, which is so much high as compared to the PCR rates in tumor, which we saw was only 26%. This is one important thing which you should note. The other thing was that since these many patients, about 50 to 60% patients can have a PCR, so 50 to 60% patients can be offered sentinel lymph node procedure. Again, it impacts on the lymphedema, and these many patients will not have to undergo axillary lymph node dissection. Now, later on, you will see that this response of node also allows personalization of radiotherapy. Now, the other important thing which you should note is that the nodal PCR rates also varies according to biology. If you see in the first column, which is hormone receptor positive, various studies showed that the PCR rates ranged from 21 to about 45%. While in HER2 enriched, it ranges so much higher, 50 to about 79, 80%. And in triple negative, it ranges from 50 to 70%. So what do we infer? That HER2 enriched and TNBCs have higher rates of nodal PCR, which is very important because these two subsets have a worst biology. Now, why am I harping on PCR? Does it impact on survival? Yes. It impacts on survival. As you see in both the studies, the blue line is the one of those who achieve PCR, and it is so much above the yellow line. So the PCR, those patients who achieve PCR are long-term survivors. The other important thing for patients who achieve PCR is, for example, in a lymph node, if the patient achieves PCR, only one radical modality is enough. Patient will have only sentinel lymph node procedure, as well as no radiotherapy will be needed in the axilla. Now, since PCR has become so important, and in the worst subsets, that is HER2 enriched, the investigators then added trastuzumab to these patients, and then one agent was added, and then dual agent was added. So let's see what is the impact of adding dual agents to the standard chemotherapy. In the left side, you will see that only HER2 agents, if they are given, then the PCR rate is 29%. In the middle bar is where you add dual, which is the standard of care, that is trastuzumab with pertuzumab, leads to a pathological CR of 62%. And if you further intensify chemotherapy, you can achieve 80% pathological CR. Again, in this study, they saw that those who achieved PCR were long-term survivors, the red line, the above. And this also came out to be true in the various subsets. Now, coming to the other worst biology, that is triple negative. People were working on other agents to achieve a better PCR. So, people were trying with nab-pacli and gemcitabine, and then they tried with nab-pacli and carboplatin. Nowadays, carboplatin is said, it is said that if you incorporate in triple negative, it is better. Now, if you see in this study, in a responder, the right side of the bar shows that as compared to a non-responder, which gives a PCR rate of 30%, the responder, you get a PCR rate of 52% with platin, which is far more than with gemcitabine. So, what else in triple negative? Nowadays, people have started establishing the role of immunotherapy in this worst biology patient. And since I'm talking about PCR only, in this first study, you can see that the PCR improved by 15%, from 50% to 65% if pembrolizumab was added to chemotherapy. So again, this is a very important a part of the, it is gradually becoming important, provided patient can afford it. Now we have seen all the subsets and most of the important chemotherapy regimes. And now let's see what are the important loco-regional management strategies to adopt in LABC. So first of all, if you see for surgery of the breast, and I've already told you that initially people were thinking that you should excise the entire pre-chemo volume, but now it is clear that the residual disease only needs to be operated. And the original tumor area should be operated only in cases which have not responded, refractory patients. Now coming to the other important thing, that is the margins. So it has become established that even in these patients which have been downstage with neoadjuvant chemotherapy, no tumor on inked margin is enough. And it is only in refractory patients or multifocal disease patients that a 2 mm margin is required. Now coming to the role of sentinel lymph node biopsy in a clinically node negative, and which is appropriate in a clinically node negative after neoadjuvant systemic chemotherapy. And if it is a node positive, then axillary dissection is the standard of care. Now let's see what is the results of sentinel lymph node procedure after systemic chemotherapy in node positive patients. So these are the two standard trials, Sentina and ACO-SOG. So in these patients, in this study, most of the patients were clinically M0 after neoadjuvant chemotherapy. And what was the identification rate? It ranged from 80 to 90. So it's not the best. The other important problem was that the false negative rate was also a little bit high, 13 to 14%. So, so then gradually further studies revealed that the false negativity rate can be decreased to 7% if we use a dual tracer and if we remove more than sentinel lymph nodes. And so let's see what is the improvement with removal of 3 sentinel lymph nodes. So as you see in both the studies which I mentioned, the first line shows the false negativity is as high as 30% with single lymph node removal. The third line shows that if you remove more than 2 sentinel lymph nodes, the false negativity rate decreases to 5 to 10%. And if you use dual tracer, the false negativity rate was still 8 to 10%. So how to improve the false negativity rate? So therefore, there came a concept of targeting the lymph nodes which were positive. So what does this mean? That when a patient of clinically node positive comes to us, you put a metallic clip on that. And after chemotherapy, you target these lymph nodes for removal. You have to target this lymph node also, apart from the sentinel lymph nodes which you are removing. So did false negativity rate improve? Yes, it came down to 2%. And the positivity rate was 97%. And after this, it has become the standard of care. Now, the other thing which is important is that the presence of isolated tumor cells or microscopic tumor cells in a lymph node is also called as node positive bi. So as you can see in the first column, the YPN0s have a survival of about 89%. And the moment it has isolated tumor cells, it falls down by 6%. And if you have microscopic tumor cells, it falls down another 3-4%. And N1s have a survival of about 78%. And N2s, N3s further down to 61%. So therefore, based on this, the staging systems also mention the ITCs and the microscopic cells. Now that we have in short dealt with the loco-regional surgical, I haven't talked about the oncoplastic procedures because my topic was to basically deal with loco-regional radiotherapy. So I'll be talking about the most important slide of this presentation, and this is based on the results from NSABP. So this graph tells you that the yellow bars are the ipsilateral breast recurrences, and the blue ones are the regional recurrences. The upper graph shows postmenopausal women and the lower one premenopausal women. Now the y-axis shows the incidence of locoregional recurrence, and the x-axis shows the various types of response to chemotherapy. And the left part of the graph is clinically node negative, and the right side is the node positive. So, as you see here, that those patients who achieved YPN0 and a pathologic CR in the tumor, both CR in the tumor as well as node, they had a 5% chance of breast recurrences and only 1% chance of locoregional recurrence. So this graph is about the lumpectomy patients. Later on, I will show the mastectomy patients. And as you move towards the right and the patients become node positive, the incidence of recurrence increases to 7% in the node positive patient, that is in the breast, and locoregional also increases. Now let's see whether it is some difference in the premenopausal women. So in the premenopausal women, the total PCR patients had a similar recurrence rates in node negative, but in the node positive, the recurrence rate increased. It was slightly more than that of postmenopausal patients. So what do we infer? That apart from pathologic CR, the menopausal status is also important. Now let's see the other part of the graph, that is mastectomy patients. The upper part of the graph in mastectomy is only T2, less than 5 centimeter tumors, and the lower is more than 5 centimeter. And here the yellow bars and the blue bars show the same thing. So as you move towards the right from the node negative to the node positive, what we see is that the local recurrence is 2.4%. and the loco-regional is also 2.2 to 4%. These are the pathological CR patients. Now, in a node positive, both the incidences increase to about 10%. And as the tumor size increases, now you should remember that NSCBP patients, they did not receive radiotherapy in mastectomy patients. Only the BCS patients had been given radiotherapy. So, and as the tumor size increases, the incidence of locoregional recurrences also increases. So and other thing which is important to infer from this slide is that in a pathologic CR patient, the local recurrence as well as the loco-regional recurrence is so low, 3 to 4%. So, what do we understand is that they can do away with post-mastectomy radiotherapy or axillary and SCF radiotherapy. So, this is one important thing. The other thing is that in node-positive patients, the recurrence rates are higher, so you need to add radiotherapy. So, based on this study, this is the same thing which shows in terms of hazard ratio, so I will not talk about that. So what did we understand is that irrespective of, one thing which is important here is that irrespective of breast PCR, it is the nodal PCR which is more important. The hazard ratio is 2.7. So that is why the further studies are testing and they are stratifying patients based on only nodal PCR and not on the tumor. So, and there are three studies which are going on, which has not yet revealed the result, not yet published their result. But this is one study, the results of which were presented in ESTRO in August last year, which is not a randomized study, but it is a Dutch registry study. And again, these patients were the same, T1 to 2 N1s. And now let's see what were the risk stratification. Okay. I'm very sorry, this intermediate is not showing, but I can speak. Okay, so what were the low risk? The low risk patients, as we can understand, would be obviously YP-N0. YP-N0, I hope the residents understand that those patients who achieve N0 after chemo are written as YP-N0. And these are the patients who have undergone axillary lymph node dissection. We are not talking about sentinel lymph node now. So in these patients who achieved YP-N0 as revealed on axillary lymph node dissection, so those patients who had undergone a BCS, in these patients only breast radiotherapy was given. And those patients who had undergone mastectomy, no radiotherapy was given. While what we practice is that irrespective of N0 status, we are giving radiotherapy to one and all. But it is these studies which are going to change the guidelines. Now the intermediate is YP-N1 on axillary lymph node dissection. So in this also what they did was that they gave only whole breast radiotherapy and they gave radiotherapy to the SCF, the level 3 and 4 of the axilla. That means level 3 of axilla and SCF. Now the high risk were YP-N2. In this only those patients, the middle column is that of BCS patients. So in those patients who had undergone BCS received the standard radiotherapy to the breast and tumor bed. And those patients who underwent, and here they gave SCF-RT, and those patients who had undergone mastectomy, they were given RT to the chest wall and axilla and SCF-RT. Now, now the intermediate has come. I'm so sorry. So again, I would like to just check whether I spoke the right thing. In YP-N1, the patients who underwent BCS got standard breast RT, and in the mastectomy patients, they got radiotherapy to the chest wall. And they also got radiotherapy to, okay. And so this is most other important thing is that they did not get SCF and axillary RT, which is what we practice, because there were no studies yet available. And it is only in YP-N2 that they say that axillary SCF-RT is necessary. So let's see what did the results reveal. So in the low risk, if the patient got the radiotherapy according to guidelines, the loco-renal recurrence was only 2.3%. In intermediate risk, the loco-renal recurrence was only 1%. So what does this tell us? That in YP-N1, patients who have undergone an axillary lymph node dissection, we need not give regional nodal irradiation. Only chest wall RT is good enough. Now let's see what about the high risk patient, that is YP-N2. In YP-N2 also the local recurrence rate is very low, 1.6%. And so therefore what we practice is that we give, so that means that giving SCF-RT gives good local control. So you need not unnecessarily irradiate the axilla. Now let's see what are the survival in both the three groups. Now, if you look at the lowest right side, Kaplan-Meier, the survival in low and intermediate is the same, 95% with this approach. And it is only the high risk patients where the survival is lower, that is 83%. But we have to also keep in mind that these were patients of T1 to T2 and N1 only to start with. So this is one study which has been only presented, not yet published. And so this gives us some idea of what is happening. And these are the other two studies which are going on at NEC. And I'm not going to talk in detail what is the trial design. The other is this American study, the RTOG study, which is also testing the same thing, whether PCR patients need a chest wall RT or not. Now we have talked enough about the patients who have responded and have got operated. So what about patients who either progress or are still unresectable, they just have stable disease? Is there a role of pre-operative radiotherapy? So there are few studies which have been published and many which are ongoing, but the guidelines say that yes, you should give radiotherapy in such patients with a hope that some downstaging is possible. Now this first study, if you see, this was done and published long time back, I think in 2006. And it was reported in stage 2 patients, in 57 patients, and they gave 50 gray and they achieved a pathologic CR of 27%. And recently this year, they have published this hypofractionated 5-fraction schedule, and in only 10 patients, and compared it with 10 patients with standard radiotherapy. And with hypofractionation, they found that the pathologic CR is 60%. Now, this study, the third study, is published again in 2000. And here they have published on 270 patients, and the radiotherapy dose was 60 gray. But this was since published, I think, in 1990s. I forgot to put the year. Here, the pathologic CR was 30%. The largest series of preoperative radiotherapy is from our country, from Dr. Shanta, and in 1,000 patients. But the dose that they gave was only 40 gray. But to our surprise, the pathologic CRs were 45%. So this shows that one should surely attempt preoperative radiotherapy in patients who are either stable or are progressing on chemotherapy. Now that we have given our chemotherapy, done the surgery, and then we have also given radiotherapy, what to do for those patients who are partial responders? They have residual disease on histopathology. So in these patients, you should give maintenance chemotherapy. Now, this CREATEX study was published in 2017, I believe. And here what they did was in patients who were triple negative, in these patients, they randomized patients to either capecitabine or no further therapy. And it was only in the hormone receptor positive patients that hormonal therapy was given. So what they found was in patients who received capecitabine, the 5-year disease-free survival improved by about 7%, that is 74% versus 68%. And the OS also improved by 6%, which is a big gain for advanced tumors. So 6 cycles of capecitabine is the standard of care in TNBC with residual disease. Now coming to the role of maintenance anti-HER2 therapy in HER2 enriched tumors. So this was the Catherine study where they gave either trastuzumab in one arm, which is the standard of care, versus TDM1 for 14 cycles, that is almost a year. So what they found was, if we look at the freedom from distant recurrence, was better with TDM1, and it was how much better? 90% as compared to 83%. And the overall survival improved by about 30%. So therefore, after publication of this study, it has become the standard of care, though it is difficult to give in our patients because it is so costly. And we continue to give trastuzumab for about a year. Now, the third study, which has been published in about, I think, 2021, and here they have seen that abemaciclib, which is a CDK4/6 inhibitor, if you give that to, oh, I'm so sorry, this has come up, okay, never mind. So the survivals were behind this, but I think animation is not there. So abemaciclib has shown an improvement as compared to endocrine therapy alone. So what do we do in ER positive patients, the hormone receptor positive patients? After completion of the entire therapy, we put them on endocrine therapy, which is the standard of care. So does abemaciclib along with the standard of care hormone therapy improve the results? So it does improve. And if you look at this forest plot, here you see that it works more in premenopausal. And if you look at the tumor size, irrespective of the tumor size, whether it is less than 2 or more than 5, it works well. And if even in the higher grade, it works more. And irrespective of the tumor stage, it works. Okay, so the survival, you can only see a part of the survival, so there is slight difference. Now, the other thing which has come up is that many of the TNBCs and hormone receptor positive patients could be having BRCA 1 or 2 mutations, and we should test the young women with breast cancer for BRCA positivity. And it has been seen that PARP inhibitor, if it is added to the BRCA mutated patients, it has a bearing on both the distant disease-free survival, which improves by 7%, and even this overall survival, it improves by about 4%. So if the patient can afford, then it should be given for about, I think it is 2 years. So this is all about maintenance therapy. So I would like to summarize my talk by telling the audience that the index clinical stage does not decide the post-surgical management, which we have seen just now. It is only the downstaged clinical stage which decides both the surgery as well as the radiotherapy and the maintenance chemotherapy. For a PCR node, or for a node which has attained a pathological complete response, which happens in about 50 to 60% patients, a sentinel lymph node is good enough. Now, again, in a pathological CR in node is the most important factor, and it is the only factor which is used to stratify patients for different kinds of radiotherapy, and which is being tested nowadays. The other thing which we learned was that in patients who achieve pathological CR, only one adjuvant modality is enough. And if the patient has 1 or 2 sentinel lymph nodes, then and the patient has not undergone axillary radiotherapy, then in these patients, axillary radiotherapy can be given. There is no need to further dissect it. But if there is more than 3, then you have to undergo axillary lymph node dissection and give only level 3, 4 of radiotherapy. So this is all I had to talk, because for the MD students, I think this much is enough. More than that would confuse them. And there are many more studies which talks about de-escalation, but I have purposely not mentioned that. So if there are any questions, let me see in the chat box.
Yeah, ma'am, there's one question by Dr. Debanjan. Basically, the question is that in Dr. Shanta's study, when the NRT was given 40 gray, it was by hyperfractionated scheme or by conventional fractionation?
It was conventionally fractionated. And that is why the dose was less. But surprisingly, it showed 45% of pathological CR, and they had given not the standard chemotherapy which is nowadays given. They had given CMF or many more older chemotherapy, and it is a 10-year results. I think more than that, 15-year results. So therefore, even the older kind of chemotherapy patients were there.
The second question is, ma'am, that what is the role of IMN, radiation in locally advanced medially located tumors post NACT?
See, the West people, they still advocate IMN in high-risk patients, but we have even published the results from our institute, and we are not practicing it. Even though the Western literature talks about IMN radiation, even in early tumors, we are not practicing it. And the recurrence rates are also not high. What we have to improve upon is on the chemotherapy too, because they have a poorer distant mets rate. And I just showed you the Dutch registry study, irrespective of the quadrant, the recurrence rates were so low.
Another question, ma'am, what is the role of whole breast radiotherapy after complete response of metastatic lesion after NACT?
Just a moment. Role of whole breast RT after CR. This is a good question which we often see in our clinic. But the role of whole breast RT after NACT is evolving. There are no guidelines, but people in Eastro last year, they talked about it. There was a talk. But it's not there in the guidelines. If you want to do a study, you can do on it and publish it. It will get published fast. And even I tend to think we should give radiotherapy, but it's not for the MD students. There is no role.
Next question, ma'am. In dissected axilla, when do you treat level 1 and level 2 axilla?
So in dissected axilla, and if we in a well dissected axilla, we never treat level 1 and 2. We only treat if the nodal burden is very high. For example, 6 to 7 or 10 to 12 lymph nodes we tend to treat, but it is only if there is perinodal spread that we tend to treat. But otherwise, if we have also published our results, the local recurrences in the axilla is only 4 to 5%.
There is no more question chat box, but ma'am,
So other question is, if the index stage was N3, and after NACT followed by MRM, it becomes YPN0. So you should give RT to the chest wall, but not to the axilla. But we have to give RT to the SCF and level 3.
Now, what is the role of cisplatin in triple negative breast cancer?
So cisplatin is well established. People say that either give a chemotherapy consisting of cisplatin and other agents, And some say that if the patient doesn't respond, then you give cisplatin. So that is it. There, it is definitely there.
Next question is, Paris said that more than 4 lymph nodes with extensive extracapsular extension to receive axillary RT. What is the extensive extra?
Extensive means, if as I told you, my 8 to 10 lymph nodes are there, the nodal burden is that high, and there is extracapsular extension in them. This is what it means. If there are about 8 to 12 lymph nodes which come out to be positive even after NACT, this is what it means.
Do you practice post-axilla boost?
No, never. Matlab, if at all we have to see, posterior axillary boost is a technique which has to be given in fat patients if you are not able to achieve your 93% dose to the center of the axilla.
What is your opinion regarding the definite radiation? Suppose a patient of LABC receives the complete clinical response after an NACT patient very reluctant for the surgery. So, what do you think of the definite radiation in this case?
I didn't understand this question. Can you repeat it again?
Yeah, ma'am. Suppose a case of the LABC comes to you and you give the neoadjuvant chemotherapy and patient gets the complete clinical response and patient very reluctant for the surgery. Then what is the role of definite radiation in this case?
See, if the patient is reluctant, then the standard of care is surgery. But in a trial mode, if you want to give, because even I have a patient who was an elderly and who achieved complete, she had a very big tumor, she achieved CR and she doesn't want to undergo surgery. But I have advised her to undergo surgery because that is the standard of care. But in a trial mode, you can definitely address this question.
The next question, how to decide whether should start hormonal therapy or chemotherapy as neoadjuvant?
See, neoadjuvant hormonal therapy is not the standard of care. It should only be given in patients who are too frail to undergo chemotherapy or who have comorbidity like heart disease, and in those patients you can't give chemotherapy. So it is only in these patients of LABCs that you should give hormonal therapy. But maybe later on with evolvement of newer drugs. But why? Because they are very slow, they give very slow response. Letrozole was the only standard of care. Now with the results of abemaciclib, I think it has come in the ABC6 guidelines, but still it is not yet published, but it is only in one of the German papers I saw that it has been mentioned. So it has come in the ABC guidelines, which happened only in November 21. So, but maybe later on, but as of now, it is not the standard of care.
Second question, ma'am, if IFD is more than 20 centimeter, then post-axillary boost should be given or not?
Okay. So the 20 centimeters is how much? Oh, 20 centimeters is too much. IFD is interfere. Or definitely this patient will need a posterior axillary boost. That is what I said.
Should we give hormone therapy along with radiotherapy?
Yeah. Initially it was contraindicated, now you can. But not with chemo, not with chemo.
We can give tamoxifen also along with radiation?
Yes, yes. When we were doing MD, it was contraindicated, now you can. But it should not be given with chemotherapy.
I think there's no more question, ma'am, now. Ma'am, thank you so much for such a wonderful lecture and for answering all the queries of our student. Thank you for sparing time for this. Thank you so much. Thank you all the participants. Thank you. Good night, everyone.